Good afternoon, everyone. It's a delight to have all of you here. I'm Keith Mueller, the Interim Dean of the College of Public Health, and I'm very pleased to welcome everyone to the 2017 Richard and Barbara Hansen Distinguished Lecture. It is our distinct honor today to recognize Dr. Camara Jones as this year's Hansen Award recipient. Dr. Jones is a family physician and epidemiologist whose work focuses on the impact of racism on health and well-being of communities throughout our nation. She is a leading national advocate for health equity and better understanding of the social determinants of health and the social determinants of equity. Her work on race-associated differences in health outcomes goes beyond documenting those differences to vigorously investigating the structural causes of the differences. As a teacher, her allegories on race and racism illuminate topics that are otherwise very difficult for Americans to understand or discuss. We are fortunate that the Hansen Leadership Award offers us this unique opportunity to honor individuals such as Dr. Jones, national leaders who have made sustained contributions in the public health field, and to bring those individuals to the University of Iowa to interact with students, faculty, staff, and the wider community. This annual award is made possible by a generous gift from Richard and Barbara Hansen of Iowa City, and we're very grateful to the Hansens. Although Dick and Barb are not able to be with us today, please join me in thanking them for their outstanding support of our college. Dr. Jones is a senior fellow at the Satcher Health Leadership Institute and Cardiovascular Research Institute at the Morehouse School of Medicine in Atlanta. She received her bachelor's degree from Wellesley College, her MD from Stanford University School of Medicine, and both her MPH and PhD degrees from the Johns Hopkins School of Hygiene and Public Health. She also completed residency training in general preventive medicine and family practice. Previously, Dr. Jones was an assistant professor at the Harvard School of Public Health from 1994 to 2000. From 2000 to 2010, she served as research director on social determinants of health and equity within the National Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control and Prevention. Dr. Jones has served in top leadership roles at the national level, including president of the American Public Health Association during 2016. She is a member of the World Health Organization's Scientific Resource Group on Equity and Health and the National Board of Public Health Examiners, the Board of Directors of the American College of Epidemiology, and the Boards of Directors of the National Women's Health Imperative. In 2011, she received the John Snow Award from the American Public Health Association and the Royal Society for Public Health in recognition of her enduring contributions to public health through epidemiologic methods and practice. It is now my great pleasure to welcome Dr. Camara Jones and to present her with the 2017 Hansen Leadership Award. Dr. Jones, congratulations, and we very much look forward to your remarks on achieving health equity, tools for a national campaign against racism.
Thank you, and thank all of you for being here to share in what I hope will become a conversation on achieving health equity. As president of the American Public Health Association, and how is the sound for you all in the back? Is the sound good? And how is the sound for you all in the front? It's good? Okay, so good. As president of the American Public Health Association last year, I actually launched our association, and as many communities and partner organizations as wanted to join us on my presidential initiative, which was to launch a national campaign against racism with 3 tasks: to name racism, to say the word, to ask how is racism operating here, and then to organize and strategize to act. What I'm going to share with you today are some of the allegories and definitions and frameworks that I went to 40 states last year sharing. Usually, I like to have 2 hours, so that I can stop and we can talk about this and that and the other. But I'm not going to be able to do that today because our time is a bit constrained. So I'm going to go straight through sharing my allegories and the like, and then we'll have time for questions at the end. However, I must say, because this is how I really feel about things, if at any time I say something that really makes you want to rise up out of your seat because you think I'm wrong, you want to challenge me, or you think, oh my God, she's speaking my life, or you want to say amen, if there's something that you really, if there's something that you really want to say, I am happy to stop at any moment, okay? And maybe we won't get through all the slides because I like to have these as conversations, not lectures, okay? So I'm just inviting you with that real thing. Now you might ask me, well, let me just say, I am going to present you with the why of a national campaign against racism and then the how. And so the why starts with understanding different levels of health intervention. Why should people interested in health, especially interested in public health, be concerned with racism at all? I call this my cliff analogy, describing different levels of health intervention. Here we go. Whoops! Boom! Somebody just fell off of the cliff of good health. And if that were you or somebody in your family, you would be delighted to find an ambulance at the bottom of the cliff to speed you on to care, right? But if we were concerned about other people who might come along that cliff face, so if we were concerned about community health, population health, public health, we might well ask ourselves, what could we put in place as a health intervention besides just stationing lots of ambulances at the bottom of the cliff? So somebody in the room is going to say, I know, let's put a net halfway down. That way, if people fall, we can catch them before they get crunched up at the bottom. So that's an excellent idea. We can all agree on that. Although the more you think about it, nets do have holes in them, so some people might fall through the cracks. But never mind. Let's make that a trampoline halfway down. No holes in a trampoline. But even if we have a trampoline halfway down that cliff, we might well find ourselves with lots of people just bouncing up and down at half functionality, not able to get back to the top of the cliff. So what else could we put in place as a health intervention? Well, clearly we need to be thinking about a fence at the edge of the cliff to keep people from falling in the first place. But even that fence is going to have to be a very, very strong fence if there's a lot of population pressure against it. So what else could we do as a health intervention? Well, we could move the population away from the edge of the cliff. So let me describe the interventions that I have depicted so far, where the ambulance at the bottom of the cliff, that represents medical care, as well as what we on the public health side of things describe as tertiary prevention. So you'll be familiar with the 3 levels of prevention: primary, secondary, tertiary. Tertiary prevention is preventing complications from disease that's already manifest. So that's your ambulance right there. The net, or trampoline halfway down, these are our safety net programs, often found in our social services, as well as secondary prevention, early detection, screening programs, which could be in clinical settings or community settings. The fence at the edge of the cliff represents primary prevention, keeping bad things from happening in the first place. So that could be immunizations, or it could be policy interventions, like a tobacco 21 policy to prevent easy access of young people to tobacco products. And then moving the population away from the edge of the cliff, that's what we describe as addressing the social determinants of health. Those determinants of health and illness that are outside of the individual, beyond our individual genes, and even beyond our individual behaviors, where these social determinants of health are the context in which our behaviors arise and either convey risk or protection. And these contexts of our lives include individual contexts like individual education, occupation, income, wealth, but they also include, so addressing poverty, for example, is a way of addressing a social determinant of health. They also include neighborhood context. So, can you get fresh fruits and vegetables easily or affordably in your neighborhood, or do you instead live in what some people describe as a food desert or a fast food swamp? Are there jobs in your neighborhood, or do you have to, even if there aren't jobs, is there transportation to a job? What's the quality of housing? And I know we're in a rural state, so there are many social determinants of health that have to do with just physical access to resources. Here we are in Iowa City. That may not be top of mind, but many of you might be from rural parts of Iowa. What is the availability even of, medical resources and the like? You know, what is the quality of education? All of these things. So addressing adverse neighborhood or rural setting conditions is a way of addressing social determinants of health. Addressing occupational hazards, looking at opportunity structures, so all of that. So let's say we were looking at a health outcome like infant mortality. Ambulance might represent neonatal intensive care units. The net or trampoline might be prenatal care, you know, screening pregnant women for bad outcomes. The fence might be excellent maternal nutrition, so maybe women, infants, and children WIC program support. Moving the population away from the edge of the cliff might be excellent educational opportunity so that young girls don't have babies so soon, or maybe a living wage, so that pregnant women aren't living in poverty. Lots of, you know, you could take any outcome you want to, health outcome or educational outcome or social justice, any outcome, and put it along this cliff. It was useful for having a conversation with communities, because we know we need some of all of this, but how do we want to spend our health resources? We could go to the State House, we could go to Congress with this. But as useful as this diagram is, there's a huge fatal flaw. There's a huge fatal flaw in this diagram, because so far as I presented it, it doesn't yet equip us to talk about how health disparities arise, right? So I want to shift gears for just a moment, talk about how health disparities arise, and then we'll come back to the cliff. Now, there are health disparities along many axes. I'm going to talk right now about racial ethnic health disparities, where unfortunately we have lots of evidence about differences in the quality of care received within the healthcare system by race or ethnicity, even for people who are in the same system, even for people who have the same insurance coverage. So the Institute of Medicine in 2002 released its unequal treatment report, which pulled together what were then hundreds of studies. If we were to do the same thing today, it would be thousands of studies documenting differences, for example, in how vigorously your chest pain might be investigated or treated, depending on your race, or differences in how much pain medication you might get if you walked into an emergency department with a long bone fracture, depending on your ethnicity. And when the Institute of Medicine released this report, it was like a lightning bolt went through at least healthcare providers. It was an important thing of shining the bright light of inquiry on this question: is there differential treatment? But even that IOM panel said, we know that this is not the end all and be all of how health disparities arise, because some people can't even access a healthcare system in the first place. So a second level at which health disparities arise are differences in access to healthcare. But then I'm hoping everybody in this room recognizes that health is not created within the health sector. So there's a third level at which health disparities arise, which are differences in our life opportunities, exposures, and stresses, differences in the conditions of our lives that are making some individuals and communities sicker than others in the first place. And when you think about these three levels at which health disparities arise, differences in quality of care, differences in access to care, differences in underlying exposures and opportunities, you could actually draw it as a pyramid. Or better yet, honestly, I think it's more like an iceberg, where the huge hidden base are the differences in the conditions of our lives. And then, very often, the same people who've been made sicker are the same ones who are frustrated, often frustrated because of limited access to the healthcare system. And then even the lucky ones who get into the system are sometimes further injured because of differences in quality of care. So thinking about those three levels at which health disparities arise, we're going to go back to the cliff. But now, we're going to recognize we're really not dealing with a flat two-dimensional cliff, but actually we're dealing with a three-dimensional cliff. And in some parts of that three-dimensional cliff, there might be an ambulance all along the way, but in some parts, maybe that ambulance has a flat tire, so it's slow, or goes off in the wrong direction, or maybe there's no ambulance there at all, and maybe there's no net nor fence. And usually, at those parts of the cliff, the population is being pushed closer to the edge. So now, let me label the observations about this three-dimensional cliff with how health disparities arise, where the differences in quality of care are represented when the ambulance is there, but it slower goes off in the wrong direction. The differences in access to care are represented by no ambulance, no net, no fence. Differences in, underlying exposures and opportunities are represented by the closer proximity of that greenie population to the edge. So now that we recognize that we're really dealing with a three-dimensional cliff, there's a whole new set of questions that arise. The first question, of course, is how did the cliff become three-dimensional? That's usually because of historical injustices that are perpetuated by present-day contemporary structural factors. But given that the cliff is three-dimensional, we also need to ask now, why are there differences in how resources are distributed along the cliff face? And why are there differences in who's found at different parts of the cliff? Why are the oranges back here in a way and the greenies being pushed closer to the edge? And when you start asking and addressing these kinds of questions, you're now doing what I describe as addressing the social determinants of equity, which differ from the social determinants of health. The social determinants of health, you remember I talked about addressing poverty or adverse neighborhood conditions, moving the population away from the edge of the cliff. The social determinants of equity are systems of power that can distribute resources and populations along that cliff face. These social determinants of equity, these systems of power include racism, sexism, heterosexism, ableism, regionalism, economic systems like capitalism and the like. And actually, with this cliff, I've distilled 3 different dimensions of health intervention. If you go back to your junior high or high school geometry, 1 dimension is a line, 2 dimensions is a flat plane, 3 dimensions is space. Well, along the line at the edge of the cliff is where we can display all of our curative and preventive health services right there. Actually, if you say the word health in most parts of this country, people will immediately go to health care or health services. So when you say the word health, most people are thinking along that line at the edge of the cliff. In fact, our whole conversation about the Affordable Care Act was along the edge of the cliff. The repeal and replace, thank goodness from my point of view as a public health provider, thank goodness we didn't go there. The Affordable Care Act is not the end all and be all, but I mean, oh my God, well, it's still under assault, this we see, right? I actually think that we will eventually join the rest of the developed world in having universal access to high quality health care at some point. I don't know how soon or how much later. But even that is going to be an edge of the cliff conversation. Now, the reason that we need to push for universal access to high quality health care is not because that in and of itself is going to greatly result in large and sustained improvements in health outcomes or the elimination of health disparities. The reason that we need universal access to high quality health care is because that is how a civilized society values all of its people equally. It's as simple as that, right? But even when we get there, that's still going to be an edge of the cliff thing. And we can overwhelm any system if everybody's pushed up against the edge of it. So we must move into that second dimension, which I can display in a flat plane. We have to be talking about addressing the social determinants of health, including poverty, adverse neighborhood conditions, and the like, if we want to have large and sustained improvements in health outcomes. But the trick there is that if we are about moving the population away from the edge of the cliff without recognizing that we're really dealing with a 3-dimensional cliff, we're at risk of moving some of the population, but not all of the population, and actually making health disparities worse. So we must address these social determinants of equity, including racism, sexism, heterosexism, ableism, regionalism, capitalism, and the like, if we want to have social justice and eliminate health disparities. Now, this is often the point in which I open the floor for discussion, but I'm not going to do that. I'm going to just share 2 questions that have come up in past discussions and then carry on. I have been asked a few times, Dr. Jones, this is all very interesting, and especially we're all public health people here. Why are we spending so much money on ambulances at the bottom of the cliff, right? And there are 3 answers. There are many answers to that. I'm going to just propose 3 of them right now. One is that we as a nation have not really understood that an ounce of prevention is worth a pound of cure, obviously, right? But the reason has to do with the second thing. There's a lot of money being made in those ambulances at the bottom of the cliff, right? The hospitals are making money, pharmaceutical companies are making money, medical device companies are making money, medical care providers are making money, a lot of money being made there. But the real core answer is the third one, which is that we as a nation are so narrowly focused on the individual that we don't even recognize that there's been a health problem or that there's a health issue until somebody falls off of the cliff. And we do not routinely measure how close is the population to the edge. We aren't even routinely measuring the strength of our fences, of our nets. And even people like me, trained as a physician, often I'm speaking to medical students or physicians who are trying to be the best ambulance drivers that we can be. scooping up bodies from the bottom of the cliff and speeding them on to care. And we need people who are the best ambulance drivers who they can be as the day job. We need people at all of these things. But people who are down there doing that aren't even looking up to wonder, is there a net above me? And how intact is that net? Is there a fence? How strong is the fence? Where is the population in relation to the edge of the cliff? And at what part of the cliff am I operating, right? So I encourage wherever you are in this room, either working now or aspiring to work, because we need people at all of these levels. Whatever your day job is, be the best that you can be. But I say that all of us as a citizens need to be concerned about calling out the three-dimensionality of the cliff and then doing something about the disproportionate distribution of resources and populations. That is our job. Another question as citizens, and we all need to engage as citizens. Another question I'm sometimes asked about this cliff is, why are the greenies all running and launching themselves over the edge of the cliff? Right? That's like, why are they eating so much fried chicken? You know, I mean, it's that like, why don't they just, you know, whoever the they is, why don't they just this and that? And so I just want to say a few things about that. Again, it's about, so we as a nation are ahistorical, so we don't even understand how the cliff became three-dimensional. We don't pay attention to that. We act as if things have always been this way, will always be this way, right? And so we need to study history to understand how things got to be there. How did they end up at that cliff? We have to understand that it's probably more slippery at where they are than further back from the edge, and every step that they try to take back might require even more effort than a step back at a different part of the cliff. It's probably more dangerous there. But the real thing is, as we look at these individuals and think about individual behaviors, we don't see the systems and structures that are pushing them to the edge. You know, I should draw a hand there, pushing them to the edge. When we are narrowly focused on the individual, it makes systems and structures either invisible or irrelevant. But usually, I'm not going to carry on with the cliff because I'm eating up all my time. What I am going to do, and that clock is not even right. Is it right? What time is it? Okay, so I have 35 more minutes. Yeah, okay, so I will speak very fast. You thought I was speaking fast? Sometimes I put this cliff here and I say, you know, I've said the word racism 2 or 3 times. Nobody fell off their chair, so let's go. So now we're going to let's go. This cliff is what I use to ease people into an understanding why we as health people or why we as a nation must address racism even as we're dealing with all this other stuff. When I say the word racism, I am clear that I am talking about a system, not an individual character flaw, not a personal moral failing, not even a psychiatric illness, as some people have suggested. A system of power and a system of doing what? It's a system that structures opportunity and assigns value. And on what basis is the opportunity structured and on what basis is the value assigned? It's based on so-called race, based on the social interpretation of how one looks, which is what we call race in this country, right? So race, let me be clear, race is not coded in our genes. There is no racial subspeciation in the human family, right? And in fact, here in Iowa City, you look at me, I'm clearly black. I have been in some parts of Brazil where you look at me and I'm just as clearly white. I've been in South Africa where you look at me and I'm just as clearly colored. Here I am, same physical appearance, but in those 3 settings, the social interpretation of my physical appearance would assign me to 3 different racial groups. And furthermore, if I were to stay in any of those settings long enough, then my health outcome would probably take on that of the group to which I've been assigned, even though I'd have the same genes in all 3 places. And I am telling you, whatever you look like in this room, there is some place on this earth where your race is different from what you think it is right here. Okay. So if race is the social interpretation of how one looks in a race-conscious society, racism is the system that's operating on that race to structure opportunity and assign value. What are the impacts of racism, of this system? Well, when we do think or talk about racism at all in this country, which is not very often, sometimes for some people it takes a Charlottesville, Virginia to say, oh, racism exists, and then after 3 weeks, okay, it's petered out again and we forget, because in this country many people are in denial of the continued existence and profound impacts of racism on the health and well-being of the nation, right? So when we do think about it, we finally get to the fact, oh my God, yes, it's unfairly disadvantaging some individuals and communities. But it shouldn't take us long to recognize that every unfair disadvantage has its reciprocal unfair advantage, so that racism is also unfairly advantaging other individuals and communities. And that's the whole issue of unearned white privilege that we hardly ever talk about in this country. And it's because it makes some people uncomfortable. It makes some white people uncomfortable. And I'm not trying to make anybody in this room uncomfortable, although I recognize that maybe you just sort of had a little shiver. So I want you to sort of shake it off. I do. And stay with me, because I'm about to tell you a story that makes even talking about that reciprocal relationship between unfair disadvantage and unfair advantage, I'm going to tell you a story that makes that even easy for us to talk about. But there's a third impact of racism before I get to that story. That third impact of racism, many of us don't recognize, and that's how it saps the strength of our whole society through the waste of human resources. There are many examples of that. I'm just going to lift up two. The first is how we as a nation are not yet vigorously investing in the full, excellent public education of all of our children. Because the blinders of racism have made some people believe there's no genius in the barrios or in the ghettos or on the reservations. We can get along very well, thank you, without those kids. But of course, there's genius in all of our communities. In all of our communities. And if we were to only fully and vigorously invest in that genius, we could be doing so much better as a nation or even as a world. Might already be up on Mars farming, if that were a good idea, but wouldn't even have to go to Mars, could be in our communities, in our states, in our nation today, solving the problems of our communities if we were to invest in all that genius. Another example of how racism saps the strength of the whole society is how these same blinders that don't value all of us equally have made us as a nation complacent with what I describe as the wholesale warehousing disproportionately of so many black and brown men in our prison system, as if that didn't separate us from human potential. And if you know folks are either stuck in the prisons or cycling in and out, because when you come out with a felony conviction because you had a little bit of weed, right? And then it's hard to get a job, it's hard to get housing, can't vote in some states, I don't know what it is in Iowa, right? We need to interrupt the cycling, but we also need to interrupt the disproportionate incarceration. But what I was starting to say is, if you know these people, you know there are many geniuses caught up in this system that if only there had been some other way could be contributing quite productively to our society. And I actually think of that, of the three impacts of racism that I've outlined here, the way that it's sapping the strength of our whole society needs more media attention. It needs more data collection. I challenge you students to think about how could you document that. We need more conversations about that around all of our dinner tables so that we have more people filled with a sense of urgency to dismantle this system and put in its place a system in which all people can know and develop to their full potentials. Even here in Iowa, which is what I understand 93% white, we need to have conversations about racism. I was in an earlier conversation this morning, and somebody said, well, many people in Iowa feel like, we have to deal with a rural-urban issue, or maybe we have to deal with this and that, but racism's not really top of mind, top of agenda. And I was like, think of the word Iowa. Like, isn't that the name of a Native American people, right? Why is Iowa 93% white? Like, we are already, all right, this is already a manifestation of racism, right? Not your racism today, but in the past. And so there are three barriers. I'm going to talk about us being ahistorical. So this is something for the whole nation to be concerned with. Before I leave this slide, I also want to say one more thing. Because when I was at CDC, after 10 years, I was there as a research director on social determinants of health and equity. Moved to a different part of CDC. They really weren't into addressing racism when they found out that that's what I was doing. And in fact, one of my the story behind that is it was a new part of CDC, and everybody was coming and going. We were being formed, right? It was like a whole new thing, right? And we were trying to figure out what we were going to do. And I had been brought in to do one thing, to start an office, and then it was decided that office wasn't going to be there. So I was just continuing to do my work on the impacts of racism on the health and well-being of the nation. So I did a little brown bag lunch and did a talk, and two people were very perturbed by my talk. My division director and the associate director for science, who has to clear my presentations, who have been clearing my presentations, but did not really read them or understand what. So on this slide in particular, his response was, Camara, you already talked about the unfair disadvantage. You need to take that point about unfair advantage off of your slide. And the compromise in the short term was he allowed me to keep both of those things on there as long as I took the word unfairly off of my slide. So we could talk about disadvantage and advantage as long as we didn't characterize any as unfair. And that was really instructive for me. It made me understand that there are many people in this country who think there is disadvantage and normal. Right? Am I right? People think there's disadvantage and normal, and that's because we are ahistorical and we do not recognize that that normal is built up on a whole mountain of unfair advantage. Right? So this is a very important thing that we need to understand. But now I'm going to tell you a story that's going to make even talking about those issues a little bit easier. This story was sparked by my experience as a medical student. So I was studying with some friends in my apartment. We were studying long and hard all day, all into the evening. We got hungry, and I had no food in the apartment. So we decided we're going to go into town and find some food. So we go into town and we find a restaurant and we walk in and we sit down and the menus are presented and we order our food and the food is served. Here we are. So you're like, that's it? Okay, so that's not it. That's not the end of the story. All of us have had this experience. But as I sat there with my friends eating, I looked across the room and I noticed a sign. And the sign was a startling revelation to me about racism. So now in the backs of your minds, you're trying to say, wait, where did he say she went to medical school? Right, so I went to Stanford. But it wasn't that. You want to know, what did the sign say? The sign said open. So now I know I've lost most of you again. Let me recap. Here we are, sitting in a restaurant, eating. I look across the room, I see a sign that says open. If I hadn't thought anything more about it, I would have assumed that other hungry people could walk in, sit down, order their food and eat. But because I knew something about the two-sided nature of those signs, I recognized that now indeed the restaurant was closed due to the hour, and that hungry people just a few feet away from me, but on the other side of that sign, would not be able to come in, sit down, order their food and eat. And that's when I understood how racism structures open, closed signs in our society. That racism structures a dual reality. And for those who are sitting inside the restaurant at the table of opportunity eating, and they look up and they see a sign that says open, they don't even know there's a two-sided sign going on, because it is difficult for any of us to recognize a system of inequity that privileges us. It is difficult for men to recognize male privilege and sexism. It is difficult for white Americans to recognize white privilege and racism. It is difficult for all Americans to recognize our American privilege in the global context, except we got a little taste of that with Ebola on the health side, did we not? Yet those on the outside of the restaurant are very well aware there's a two-sided sign going on because it proclaims closed to them, but they can look through the window and see people inside eating. So back to those inside the restaurant who say, is there really a two-sided sign? Does racism really exist? I say, I know it's hard for you to know when you only see open. In fact, that's part of your privilege, not to have to know. But once you do know, you can choose to act. So it's not a scary thing to name racism, it's actually an empowering thing. It doesn't even compel you to act, but it does equip you to act. So that if you care about the people on the other side of the sign, which is an if, but if you do, then you could even talk to the restaurant owner who is, after all, inside the restaurant with you, and you can say, why don't you open the restaurant again? There are hungry people outside. Let them come in. You'll make more money, and oh, the conversations we can have. Or maybe what you'll do is pass food through the door, or maybe you'll break the glass or tear down the sign. But at least what you won't be doing is sitting back saying, wonder why those people don't just come on in and sit down and eat. Because you'll understand something about the two-sided nature of the sign. So I tell this story because it makes it easy to understand that if somebody's out, then there's a structure there that's keeping them out and is letting you in, that kind of dual nature of advantage and disadvantage. I've had a 3-hour conversation with a community group once about how could people born inside the restaurant know about the two-sided nature of the sign. And there are many ways. I mean, they could venture out. They could burst through their bubble to actually go outside the restaurant and see what's happening outside. Or they could ask the question, why aren't there more people coming in here? Or maybe they hear some chanting outside. They might say, well, why are they saying Black Lives Matter? Don't they know all lives matter? Right? They might ask, why are they saying that? To understand that there's a different reality on the other side. I don't have time to go into all of that. We could have a 3-hour conversation on that. But I commend this story to you as a way of starting some conversations. Now, so back to the restaurant, I would say there are 3 things here. You know, I talked about the tasks of a national campaign against racism being threefold. To name racism, that is to name that there is a two-sided sign going on. To ask, how is racism operating here? So then we're going to start thinking about the mechanisms, especially of institutionalized racism, and then to organize and strategize to act. Well, here's a question. How could that sign, that racism, turn into health outcomes? How could it turn into differences in asthma prevalence in some communities versus others? How could it turn into differences in obesity prevalence and the like? I find it quite useful to think about 3 levels of racism: institutionalized, personally mediated, and internalized. So I'm going to define those levels for you briefly, give you examples of how they could impact health, and then illustrate them with another one of my stories, my Gardener's Tale allegory. I'm just interested, how many of you are very familiar with the Gardener's Tale? Wow, you guys are teaching the Gardener's Tale up in here. Who is not familiar with the Gardener's Tale? Oh, okay. This is fabulous. So for the half of you guys who are familiar with the Gardener's Tale, when I start telling it, listen with different ears. Okay, listen with the ears to hear the nuances of the storytelling so that you can feel more confident telling the story back. For those of you for whom this is the first time, then just sit back and enjoy it, okay? So, but first let's do the definition. So, institutionalized racism is the system, if you will, right? It's the constellation of structures, policies, practices, norms, and values that result in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that doesn't require an identifiable perpetrator because it's been institutionalized in our customs, in our laws, background norms. This is the kind of racism that often shows up as inherited disadvantage or its reciprocal inherited advantage. And we see it in terms of material conditions as well as in terms of access to power. So, examples include differential access to quality housing or excellent educational opportunities or equal employment opportunities or even the same level of income at the same level of employment by race. And these things can clearly impact your health. Differential access to medical facilities, including linguistic access, differential access to a clean environment, and the very well-documented disproportionate placement of toxic dump sites or bus transfer stations in communities of color. And in terms of power, differential access to power is information, which could be health information or even information about our own histories or our full history as a nation. Differential access to resources, not just capital resources, but social networking resources, knowing somebody on the board. Differential access to voice as government, voice in government, voice in media, and the like. Now, sometimes about here, somebody will raise their hand and say, Dr. Jones, would you take a more careful look at the top set of examples you provided, housing, education, employment, income? Dr. Jones, isn't that what we call social class? So why do you have that on a slide about racism? Are you talking about racism, or are you really talking about social class? I know many of you are like, what's she going to say to that, right? Because it's an important question. I'm not making light, it's a very, very important question, right? My answer to that question starts with the observation that it doesn't just so happen that people of color in this country are overrepresented in poverty while white people in this country are overrepresented in wealth. That is not just a happenstance. And for each marginalized or stigmatized or oppressed group of color, there's been some initial historical injustice. So for American Indians, it was the taking of the land and the near genocide. And then the moving of the survivors to reserve lands, reservations, right? And then in some instances, there was something good found under some reservation. Oops, you got to pick the people up and move them somewhere else. There are people who for centuries were living in Mexico and they did not cross the border. The border crossed them and they now find themselves in New Mexico or California, and yet their grandchildren are being harassed still. And talking about harassment, I mean, there are many states, including Georgia, my state, that depend on migrant farm labor, but still harassing and mistreating those people in the same way that Chinese laborers who were brought here in the last century to build, 2 centuries ago, to build our railroads, were prevented by law from marrying, but prevented by law from bringing their families. Then we could go to, okay, so now let's think about Japanese folks interned during World War II. Right? And many of us are fearful that that same kind of system might be put in place today for people of Middle Eastern, North African, or looks like Muslim or whatever category might be imposed. But then let's talk about people of African descent, where the initial historical injustice was the kidnapping of West African people and our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then for the survivors and their progeny for generations, what I describe as the coerced usury of our unpaid labor for centuries to build this country. And then some people say, oh, Dr. Jones, you're going a little bit extreme on us there, you know, because, you know, we all recognize, you're talking about slavery, but we all recognize, yeah, that slavery was an unfortunate chapter in our nation's history. But Dr. Jones, the enslaved people were emancipated by 1865, and we're in 2017, so that's 152 years ago. So Dr. Jones, all else being equal, don't you think the impacts of slavery would have washed out by now? But embedded in that question is the answer. All else being equal, all else has not been equal since 1865, and all else still is not equal today. And there are what I describe as contemporary, present-day structural factors that are perpetuating each of those initial historical injustices. And those contemporary structural factors are part and parcel of institutionalized racism. So when somebody asks me, are you talking about social class or are you talking about racism? My answer is that institutionalized racism explains why we even see an association between social class and race in this country. It doesn't just so happen. Now let me also be clear that it is important for us to eliminate poverty across this land. So we need to eliminate white poverty, black poverty, Latino poverty, Indian poverty, Asian poverty, all poverty. I would go further myself, because that's how I am. I would eliminate income inequality. My husband and I disagree, but I would flatten the whole thing out. Here's my magic wand, boom, done. But if I had that power, and I did it without addressing the background structures, policies, practices, norms, and values, the mechanisms of institutionalized racism, which are very deeply embedded in the fabric of our society and were put in place to differentially shunt different populations to different possibilities, even if I were to flatten the whole thing out today, if I did that without addressing institutionalized racism, then within one generation, within 20 years, we would start to see a stratification by race again in terms of income. So this is not an either-or proposition. It is a both-and. Before I leave institutionalized racism, I want to say one more thing, which is that it can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission, and very often institutionalized racism shows up as inaction in the face of need. The second level of racism, which I describe as personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So this is what most people think of when they hear the word racism. You know, somebody did something to somebody. It includes the different idea, the prejudice, and the different action, the discrimination. It includes what some people are describing now as unconscious bias or implicit bias, as well as explicit bias. Some people call this interpersonal racism. I call it personally mediated racism because I am still understanding racism as a system. And this is the system mediated through people. How does it impact health? Well, many examples. Police brutality. I'm not going to go through the litany of names that have come to national attention in the past few years because I can't remember all of those names now. Let me just say that, so I mean, I'll tell you some of them I can. I'll lift up some, you know, so we talk about Mike Brown and Eric Garner and baby Tamir Rice and, you know, Freddie Gray and Sandra Bland and Sam Crawford. Like, there's a bunch of people, right? And I have on my phone what I call my sad list. And every time something comes to national attention, I write it on. I can't remember the names. We need to know these names, right? But it's not just the loss of those people, those geniuses, those loving people who've been killed. It's not just families that have been shattered. The impact of this police killings of unarmed black and brown men and women is that there are whole communities just bracing ourselves for the next occurrence. Because for the most part, there's been no accountability of police departments for these actions, right? That impacts health. Physician disrespect, which could be as subtle as a physician not giving a patient the full range of treatment options, because the physician figures that patient couldn't afford or wouldn't comply or wouldn't understand or whatever they assume. Or it could be quite blatant, like sterilization abuse, which has had many iterations in our nation's history. Shopkeeper vigilance, being followed around in stores, or waiter indifference, not getting quick, respectful treatment. Two manifestations of what some people call everyday racism, the microaggressions, the subtle communication of disrespect that might be related to elevated blood pressures in communities of color, blood pressures that don't even go down at night. And then teacher devaluation. That's very important, because if a teacher looks at a young child and thinks that child can't learn and puts them off in the ADD track, that child won't even know their full potential, much less have the opportunity to develop to their full potential. Now, personally mediated racism, like institutionalized, can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. But even more important is to understand that it can be unintentional as well as intentional. You do not have to have intended to do something racist to have had a racist impact. The third level of racism I'm going to define here today from the point of view of members of the stigmatized races, as acceptance by members of the stigmatized races of negative messages about our own abilities and intrinsic worth. Now, I have friends who do anti-racism training who have said, Camara, this is a bit one-sided here. What about the internalized sense of entitlement that many white people are walking around with? Isn't that also internalized racism? I agree, it is. But I had not, when I first started thinking about these things, I did not understand how that sense of entitlement could turn into adverse health outcomes. Except now I think we're seeing some of that right now. People, that sense of entitlement thwarted is turning into suicides, is turning into maybe the opioid epidemic, is turning into a lot of things. It's turning into voting. I'm going to just really jump out way on a limb and say voting against your own interest, perhaps, right? Okay, which has health impacts. I mean, okay, understood, right? Okay, I came back. I'm back. Okay, so, but on this slide, I'm speaking from the point of view of members of stigmatized races. Examples include self-devaluation, feeling maybe I'm really not as good as. Maybe I shouldn't try to graduate from high school or apply to that college or try to get that job or live in that neighborhood. It also turns into the white man's ice is colder syndrome. That's a real thing. That phrase comes from my parents' generation, and what it meant for people of color at that time, it still means for many of us today. So say that I'm black and I need a lawyer, then I might seek out a white lawyer over a black lawyer. Or if I were sick, I might prefer the white doctor over the black doctor. In fact, if my water were warm, I might go way down the street to get the white man's ice over the black man's ice, deeply believing that the white man's ice is colder, deeply internalizing the myth of white superiority. Internalized racism turns into resignation, helplessness, hopelessness, which manifests as self-destructive health behaviors, and also as not registering to vote, and also as not voting even if you are registered. And all of those things have health impacts. And really, it's about members of stigmatized races accepting the limitations to our own full humanity of the box into which we've been placed. So that when you hear young high school students of color, one of them is trying to be the valedictorian and the others are teasing her or him by saying, so-and-so's just trying to be white. We need to challenge that. Because since when did white people claim exclusive access to excellence? They did not, right? So now I'm going to illustrate these three levels of racism with my Gardener's Tale allegory. This, like most of my allegories, comes from something that I've seen with my own real eyes. So even though I only have a few minutes left, I'm going to tell you what I saw with my own real eyes and then tell this story. So this is in my life first, before we get to racism. My husband and I moved back to Baltimore for me to finish my PhD at Hopkins. We bought our first freestanding house, which had a big wraparound porch on it with flower boxes dotted all over the porch. Bought the house in October, which was not the time to plant, but when spring came, my husband, who loves to garden, ran out with our marigold seeds, going to decorate our porch. And then he ran back in because he said, Camara, some of the boxes have dirt in them, but some of these boxes are empty, so I need to go down to the gardening store. So he goes down to the gardening store and hauls back big old bags of potting soil, and then we fill up the empty boxes, and then we put equal numbers of marigold seeds in all of our boxes, and we water them all. And then because I am not the gardener in the family, at this point I'm exhausted, so I sit back, just going to be delighted, right? 3 weeks later, this is real, I walk out of my front door, onto the porch, and I look at the flower boxes, and I literally stopped in my tracks because what I saw made me think we had planted completely different species in some boxes versus the others. Because some of the boxes were full of plants, and they were, tall, vigorous-looking plants. And other boxes just had a few plants in them, and they were scrawny and scraggly-looking. Then I realized what had happened. That potting soil that my husband had bought turned out to be rich, fertile soil. So that every single seed planted in the rich, fertile soil had sprouted. The strong seed had grown very tall and vigorous, but even the weak seed had made it halfway up. That old soil that we found there turned out to be poor, rocky soil. So the weak seed planted in the poor rocky soil just died, and even the strong seed in the poor rocky soil had to struggle to make it to a middling height. And I see some of you guys nodding. So there are some gardeners right up in this auditorium. So maybe you've composted. Maybe you've composted half of your garden, right? And maybe you've seen this image with your own real eyes. And the image, of course, is about the importance of the soil, the importance of the environment. But now I'm going to take this image and I'm going to make it a story about racism by introducing a gardener. So now we're going to have a gardener who has two flower boxes, one which she knows to have rich, fertile soil and one which she knows to have poor, rocky soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms and some of the seed is going to produce red blossoms, and the gardener prefers red over pink. So what does she do? She takes the red seed, puts it in rich, fertile soil, pink seed in the poor, rocky soil. 3 weeks later, she sees in her flower boxes what I saw in mine. In that rich, fertile soil, all the red seed is sprouted. The strong red seed grows tall and vigorous. Even the weak red seed makes it halfway up. In the poor, rocky soil, the weak pink seed dies. Here comes a strong pink seed struggling to make it to a middling height. And then, in those two flower boxes, those flowers go to seed. And the next year, same thing happens. And then those flowers go to seed. And year after year after year after year, same thing happens. Till finally, about 10 years later, the gardener's looking at her flower boxes and she says, you know, I was right to prefer red over pink. So we're going to interrupt the story for a moment to say that the first part of this story is how institutionalized racism works. Where you had the initial historical injustice of the separation of the seed into the two types of soil, you had the contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, perpetuation of the inequity. But let's pick the story back up to say, well, where is personally mediated racism in the garden? Well, the gardener's looking over at red, thinking red is just beautiful. And then she looks at the pink flowers and she says, oh, those pink flowers sure are scrawny and scraggly, so she plucks off the pink blossoms before they can even go to seed. Or maybe she notices that a pink seed has blown into the rich, fertile soil, so she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where would internalized racism be in the garden? Well, the red flowers are just living their lives, enjoying being red, many of them not understanding or acknowledging that they're benefiting from enriched soil. Pink flowers are looking over at red, thinking red is mighty fine and wishing with all their hearts that they too could be red. And here come the bees, and the bees are just minding their own business, collecting nectar, but of course pollinating at the same time. So here comes a bee into one of the pink flowers, and to another pink flower, and then to this pink flower, and this flower's like, get away from me, bee. Don't bring me any of that pink pollen. I prefer the red, because the pink flower has internalized that red is better than pink. So now the question arises, what do we do to set things right in this garden? Well, we could start by addressing the internalized racism. So let's go over to the pink flowers and say, you know, pink is beautiful, power to the pink. And that is an important intervention, not making light of it. That is an important intervention. But if that's all we do, it's not going to change the situation in which the pink flowers find themselves. So you say, okay, let's address the personally mediated racism. Let's have a conversation with the gardener. Or better yet, let's have a workplace multicultural workshop for the gardener. It's all good. So we have our workshop, and in the workshop we say, dear gardener, would you please stop plucking those pink flowers? And maybe she will, and maybe she won't. But even if she does, it's still not going to change the situation in which the pink flowers find themselves. If we really want to set things right in this garden, we need to address the institutionalized racism, which means we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes, that's all right too, although it makes it easier for the gardener to continue segregating resources going forward, right? But if you keep separate boxes, what it means is that you need to enrich that poor rocky soil until it's as rich as the rich fertile soil. And when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious. So that in that intervention on the institutionalized racism, you may also address the internalized racism. Because now the pink flowers won't be looking over at red, thinking red is better, wanting to be red, right? And in that intervention on the institutionalized, you might also address the personally mediated racism. Now, I give you, the original gardener may have to go to her grave preferring red over pink. But her children who grow up and see the flowers equally beautiful will be less likely to have that kind of attitude. So this story has been to illustrate these three levels of racism and to strongly suggest that if we want to set things right in the garden, we need to at least address the institutionalized. Good to address all the levels at the same time, but at least address the institutionalized, and the other levels may take care of themselves. But there's one more question out of this story, which is, who is the gardener? After all, the gardener is the one that I gave the power to decide, the power to act, and control of resources, which are actually the elements of self-determination. Who is the gardener? Well, government is a huge part of the gardener. but not the only part. This slide used to say, who is the Gardner government? Power to decide, power to act, control of resources. That was until I went to CDC, at which point I changed my slide. But it doesn't make, but it doesn't make the government any less part of it. But there, media, foundations, corporations, communities, to the extent that they have self-determination, can all be the Gardner. But whoever the Gardner is, it is dangerous when the Gardner is allied with one group. I painted her red. That's why she prefers red over pink. And it's dangerous when she's not concerned with equity, when she can look at her flower boxes and think that her garden is beautiful, thank you, because she's not even counting the pink flowers as part of her garden. And our challenge is what to do about the Gardner. Do we make the Gardner striped or polka dotted or fuchsia? Do the pink flowers have to grow or recruit their own Gardner? Lots of questions can come out of this story. I just want to lift up for you 3 questions that have come before, and then I'm going to race in the last 2 minutes with something else. But I have to share these questions. And I know we want to have Q&A, and so, yeah. Oh, it's too much, right? So I was once asked, Dr. Jones, excuse me, please, but why should the red flowers share their soil? When I heard that question, I loved that question, because it showed me the power of this story to start conversations on racism that would otherwise be quite difficult if we were talking about racism between you and me, right? My answer to the question, why should the red flowers share their soil, is that actually that soil doesn't belong to the red flowers. It belongs to the whole garden. Okay. Second question, what if that's not the original Gardner? What if that's the Gardner's great-great-great-great-grandchild? Here we are, right? And that great-great-great-great-grandchild has always grown up seeing the flowers looking like that, may not even think there's a problem to be solved. There's a 3-part answer to that question. The first is, we must make the differences in the height and vigor of the pink and red flowers a problem requiring urgent solution. But as we are trying to urgently solve this problem, we will get nowhere unless we make those flower boxes transparent. So that's the second part of the answer. We must make those flower boxes transparent and start talking about the differences in the quality of the soil. But as we make those flower boxes transparent, the third thing is we have to be crystal clear that everybody understands that the pink seed did not just go launch themselves into that poor rocky soil, right? So we have to talk about history, and we have to talk about the Gardner's agency in all of this, how her initial preference for red over pink set up the whole situation. That is what some people call cultural racism. In our setting right now, we could describe it as white supremacist ideology. We must address that. For many years, I told this story, and I was only thinking about the quality of the soil until one day in the telling of this story in front of a group, it occurred to me that even if we were to compel the Gardner to equalize the soil today, if she continues to prefer red over pink, she will continue to privilege red over pink going forward. So we must deal with both parts of racism, the fact that it's a system that structures opportunity, that's the soil, but also assigns value, that's the Gardner's initial preference. And continuing preference for red over pink. We need to deal with both of those. The third question, which I won't answer right now because I sort of alluded to before, but what about the red seed that find themselves in that poor rocky soil, along with the pink seed that find themselves in the poor rocky soil? And I think we've heard from them, I don't have time to go there. Maybe if we have time for questions. But that is a real question. Have they believed that the red Gardner is for them? Have they believed the red Gardner who says, let's make the garden red again? Or right. But it's not doing anything, about that soil, right? Or do they join in common cause with the pink seed and the pink flowers who also find themselves in that soil? For many years, racism across centuries has been used to divide people. It divided white and black sharecroppers during the Reconstruction. It divided white and black union, people trying to be together in unions. I mean, it has been used, and it's being used again. Okay. So very quickly, may I say, if you have to go now, because I see the time, but if you can stay, I'm happy to stay. I have about 8 more minutes, realistically, 8 more minutes of stuff. So everybody who has to go now, run out. But if you can stay for 8 more minutes, I'll be done in 8 minutes. Okay. And thank you guys for staying at least through that. I'm so sorry. Too much stuff. So this question, after naming racism, we need to ask, how is racism operating here? Racism is not a cloud, it's not a miasma that we can't get a handle on. It's a system with identifiable mechanisms in our structures, policies, practices, norms, and values, where the structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms the unwritten how, and values are the why. We need to address all of these elements of decision-making, especially the structural part, the who's at the table and who's not. I also wanted to say that the definition I provided of racism can be generalized to be a definition of any system of structured inequity. What is sexism? That's a system of structuring opportunity and assigning value based on gender that unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society through the waste of human resources. There are many axes of inequity operating in our society today. And all of these are at least risk markers for how opportunity is structured and values assigned, even as some of them are also risk factors in the progression to disease. So, geography clearly in Iowa is a top of mind thing. Nationality, language, legal status, I don't know. I don't know if you have a lot of people being resettled here. I don't know, what those issues are. So you might say, Dr. Jones, this is like finally. You might say, finally, you're talking my language, right? You spend all this time talking about racism, and finally you're recognizing that all this other stuff is going on. I have always recognized this. These systems are intersecting in communities and in individuals. Why do I devote my short life to addressing race as the axis of inequity and racism as a system? It's because racism is foundational in our nation's history. And yet many people continue to be in denial of its profound impacts on the health and well-being of the nation today. So I think that all of us must address racism even as we also address some of these other systems of structured inequity. And actually, when we start making things right on the racism side, some of these others might take care of themselves. I want to provide a very brief definition of health equity. What is it? How do we get there? And how is it related to health disparities? This differs slightly from the Healthy People 2020 definition, to which I also contributed, which is a fine definition. But I have PowerPoint. I can keep thinking, that went through clearance and it's stuck, right? I define health equity as assurance of the conditions for optimal health for all people. Healthy People 2020 defines health equity as attainment of the highest level of health for all people. I agree that that's our goal, but what troubles me about that as a definition of health equity is, what if we hit that last Sunday? Are we done? And in my mind, health equity is not an outcome, it's a process. It's a very important distinction. Which process? Assurance, which is one of the three core functions of public health identified by the Institute of Medicine along with assessment and policy development. Assurance of what? Of the conditions for optimal health for whom? For all people. That's what makes it equity. How do we get there? Well, achieving health equity requires at least these three things: valuing all individuals and populations equally, recognizing and rectifying historical injustices, and providing resources according to need. How is it related to health disparities? Well, health disparities will be eliminated when health equity is achieved. Health disparities are the outcomes, the different numbers of different colored bodies at the bottom of the cliff, or the differences in the height and vigor of the pink and red flowers. Health equity is all the stuff that came before. I also want to point out, I've alluded to two of them already. There are at least three huge societal barriers to achieving health equity in our nation. One is our narrow focus on the individual, which makes our self-interest very narrowly defined. We may not even include our cousins as part of our self-interest. It means that we have a limited sense of interdependence, there but for the grace of God go I, and a limited sense of collective efficacy. We're thinking, what can I do? Not what can we do? And when you are narrowly focused on the individual, the systems and structures become invisible or irrelevant. You say to the pink flowers, reach for the sun, reach for the sky, as opposed to looking at the quality of the soil, right? The second huge societal barrier is that we as a nation are ahistorical. We act as if the present were disconnected from the past and as if the current distribution of advantage and disadvantage were just a happenstance. And also, when you're ahistorical, you think, well, I was born, things were like this way, must always have been this way, must always be this way. When you're ahistorical, you don't even have a sense of agency of changing big systems and structures. You think they're immutable. Finally, the myth of meritocracy. We in this nation endorse the story that goes something like this: if you work hard, you will make it. Now, I give you that most people who have made it have worked hard. That is true. Although not everybody who's made it has worked hard. That is also true, right? But given that there are many, many other people who are working just as hard or harder who will never make it because of an uneven playing field. And that uneven playing field has been created and sustained by racism and all these other systems of structured inequity. So that when we are in denial of racism, and you can deny racism two ways. You can deny racism by saying, I don't think racism exists. Or you can deny racism by never saying the word. Because if you never say the word and you're in a society that is in denial of racism, then you are bolstering that denial, right? But when we're in denial of racism, then we're endorsing this story that goes, this story of equal opportunity. I don't have time to go into the two babies story, but here's the last tool and then a story. Who in this room has heard of the International Convention on the Elimination of All Forms of Racial Discrimination? Raise your hand. Oh, so a few. This is actually more than most people, most places. What is it? It's an international anti-racism treaty that was adopted by the UN General Assembly way back in 1965. Who even knew there was an international anti-racism treaty, right? So let me ask you, do you think the US has signed this treaty? No, of course not, but yes. We did. Oh, but the trick here, I was trying to trick you guys. We signed the treaty. Our diplomats can go and sign any treaty they want to, but it doesn't have impact over us until our Senate ratifies it, right? You know. Okay, here's a question. You think the US Senate has ratified this treaty? 28 years later. But in 1994, we ratified the treaty. What does it mean? It means that today we have international treaty obligations to do right under this 9-page treaty. You should read it. It's only 9 pages. One of the obligations is to submit periodic reports. So our State Department submits reports about every 6 years. This is like a real thing. So here's the 69-page report that was submitted in 2013. And anybody else can submit a report that wants to. There were 82 parallel reports that the UN committee also read. And so the University of Iowa College of Public Health could also submit a parallel report. The committee considers all of this stuff, and then in 2014, they sent back to the United States our concluding observations, which are only 14 pages. So we can all read that this week, okay? It's not a telephone book. And they start out, Dear United States, thank you for your report. We remain concerned about racial profiling, residential segregation, the achievement gap in education, differential access to health care, disproportionate incarceration, and on and on and on. And not only do they remain concerned, they have specific recommendations that we are treaty-bound to address. One of the recommendations is that we adopt a national action plan to combat structural racial discrimination. It's right there, right? Another is, please let your people know about the existence of this treaty. So now, every time I talk, I do my part, right? So I want to finish with this last story. And for this story, this one was not actually sparked by something I saw with my own real eyes. It was sparked by an image in the book, Why Are All the Black Kids Sitting Together in the Cafeteria? And Other Conversations About Race by Dr. Beverly Daniel Tatum. In her book, she talks about racism for many people as a passive process. It's almost like they are just living their lives on a conveyor belt, and they're just, going to work or whatever, but they're moving inexorably through and toward racism. I want to take her image, and I want to expand on her image to talk about how we become actively anti-racist. So here we are on this conveyor belt, and we're just going to work, going to school, doing stuff, and the conveyor belt is moving on top of other people. I mean, there's some people on top of the conveyor belt, but the thing that's making it operate is, the people underneath, right? But we're just doing this, and we're moving through racism and toward racism, but we're just paying, there's a big sign up there, actually, that says racism, racism, if we would only look up. But we're not looking up because we're involved in our lives. And racism is, for most of us, passive. And some of us do look up, and they're like, racism, and then we close our eyes. So we're in denial, right? Or maybe we look up and we say, racism, oh, and then we turn around because maybe we're colorblind, but we're still on this conveyor belt, right? Right? What about us today who may believe, finally, that there is a two-sided sign going on, right? What about us today? So here we are on the conveyor belt. We look up and we say, racism, what do we need to do? Yes, we need to turn around, but we also need to take a step and another step, and we need to become actively anti-racist, and we need to walk at least as fast as the conveyor belt is moving just to stay in the same place, right? So now let me ask you this. What happens when you are walking backward on a crowded conveyor belt? You start bumping into people, right? And they're like, hey, buddy, watch out. What are you doing? Where are you going? Which is your opportunity to do the first of 3 stages of being actively anti-racist, which is to name racism. So you say, do you see where we're going? Do you want to go there, or will you turn with me? Most people would say, just get out of my way, right? Because they don't want to be disturbed out of their comfort. But maybe 1 or 2 will turn. So now you're 2 or 3 of you walking backwards, and you keep bumping into people and naming racism and inviting them to turn with you. And more will turn, never 50%, so don't even hold out for that. But more and more will turn, right? And so now, here you are, you're getting a bigger and bigger kind of mass, and now you have a critical mass, and you can start not only going further away from that sign, but you can start making your way toward what? Toward the motor that is making this system work. So now here it is. I see the motor, so now we're going to do the second stage of being actively anti-racist, which is to ask, how is racism operating here? Looking at structures, policies, practices, norms, and values. I think it's this lever. So I'm going to pull up on the lever, and the whole system shakes, and I've done it. Except racism is a very fancy system. It reconfigures itself, and it keeps on going. So it talks about the third part of being actively anti-racist, which is to organize and strategize to act. So what we really need is, I'm going to pull out this lever. You need to push a button. You need to swing that pendulum. You need to pull on this pulley. And each of us needs to take a piece of this. And I really do believe that all of us working together can dismantle this system and put in its place a system in which all people can know and develop to our full potentials. And that is our challenge, and I invite you really to join in this effort. And thank you very much for this honor and for your attention.